All right. Go ahead and get Grand Round started. Mahjabeen is a third-year resident for Grand Round. Of our graduating residents have responsibility of putting together a Grand Round on a topic of their choice. Khan has chosen are the good ways to deliver bad news. It's obviously a really important topic because how you deliver a message to a patient is really important as to how the patient understands the diagnosis or plans the prognosis. So it's a really important skill that we all need to have as we take care of patients. So Maj, I'll let you take over.
Okay. Thank you, Dr. Bocchini. Can everyone hear me? Okay. All right. Thank you guys also for coming. Like Dr. Bocchini said, you know, this is like a good topic, I thought, just to shed some light on. And I think we encounter this opportunity a lot more than we may appreciate. And so whether you're a trainee or a physician in practice, this is definitely something to be aware of. And these situations can be extremely challenging. There's the emotional stress of the event and that potential for a long-lasting effect on the family. So hopefully today you'll walk away with some skills with you. So I have no disclosures. The objectives, we'll talk about a definition of bad news, recognize the importance of effective communication between pediatricians, and discuss the current recommendations for compassionate sharing of life-altering information. And I'll go into more detail about what sharing of life-altering information exactly is. All right. I kept asking, what is this? What are you telling me you are going to do for her? They gave me answers in medical terminology. This is what I kept getting. And I'm like, could you explain that? No one really explained it to my satisfaction because I did not and still do not understand. And I would like to understand it in layman's terms. It was what you were going to do for her. So this quote really illustrated to me how powerful our words are. This is from a bereaved parent describing her inability to understand what we were going to do to care for her child. The things we take for granted that are pretty straightforward could be misunderstood or maybe even misinterpreted by the parents. And it's not the education level, but the perspective that they're coming from. So the information that we take as ordinary could be brand new, potentially frightening for these patients and our parents. So in this article, several parents commented that the complexity of the language used by the physician in communication was not what they wanted. They wanted to be told that information in layman's terms. So what is bad news? There's a few definitions. Any information which adversely and seriously affects an individual's view of his or her future. Any information that is unanticipated and perceived as negative by the person receiving the news. And any diagnosis that negatively impacts a person's future or leaves a lasting emotional effect. And these all have a very similar theme, a very recurring idea that bad news is in the eye of the beholder. So we can't estimate the impact of the news until we first determine the recipient's expectations or understanding. Implications of the phrase bad news. So over the past decades, we've heard the phrases delivering bad news, breaking bad news, giving bad news. But these all imply the following. One, a one-way flow of information. A value judgment by the physician, who may be unaware of the patient's or the family's interpretation of that information within the context of their lives. And that judgment is very much influenced by our own biases that may shape our understanding and approach to that healthcare encounter. And I wanted to emphasize this third point here with some examples. So a diagnosis of neurofibromatosis type 1 may not be the worst diagnosis we have seen, but the variability of outcome, the unpredictability of the disease, it can be very difficult for the parents. And walking in and informing them that we need more blood tests to for a needle-phobic child or an unexpected hospital stay, these can all be quite distressing for the parents. And another example is if we tell them, hey, your child has a chronic condition like diabetes or asthma, and they'll have to take medications for the rest of their lives. So these are all life-changing, but it is theirs alone to judge. So bad news is really a subjective phenomenon. It's based on the perceptual, cultural, and personal environment of the patient. And to address those prior implications, it's been proposed that we have a two-way, collaborative, family-centered communication, which is essential. And the approach to and the content of the conversation is really going to impact that family's or that patient's sense of well-being. And also avoiding the appearance of paternalism is crucial to maintaining that trusting relationship between yourself and the family. So there's actually a shift away from the phrase delivering bad news towards sharing of life-altering information or sharing unexpected news. And these phrases are validating, but they're not biased. It was a 2-minute conversation where I was told the results. At the time, I was home alone with my 3-month-old. Needless to say, I was devastated. Looking back now, I am appalled that I was given those results over the telephone. So it's hard to believe that this actually happened, but it did. And this was from a family receiving the diagnosis that their child has Williams syndrome for the first time. So why is it important to have a strategy? When faced with the responsibility of giving bad news, physicians have expressed fear of invoking emotion and expressing emotion, not knowing all the answers, and taking away patients' and families' hope. And I think that makes sense. It can be intimidating to walk into a room and have to share a new diagnosis or some life-altering information, and we may worry we don't have all of the information. We don't know the exact prognosis, and we may not be ready to manage any emotional reaction we may elicit from the parents. When in reality, evidence suggests that patients and families don't experience these negative effects if honest information is shared with them. But it can have lasting emotional injury when bad news was shared unskillfully. So I have a little video here. Hopefully it'll work.
There is a whole frame for how to begin to tell someone that their child has leukemia, for example, or that their child is likely to die. There is a way to do that, and it starts with things like making sure, simple things, making sure you have a setting that's appropriate. You're not being in the hallway when you're in an elevator. You're like, and you're doing what you do, not just with the mom and the dad that are around. So I need to
Oh, sorry. I will try to.
There is a whole frame for how to
Thanks,
begin
Brian.
to tell someone that their child has leukemia, for example, or that their child is likely to die. There is a way to do that, and it starts with things like making sure, simple things, making sure you have a setting that's appropriate. You're not being in the hallway when you're in an elevator. You're like, and you're doing what you do, not just the mom and the dad that are around. So I need to speak with you about how your child's going. Would that be okay with you? Would 9 o'clock be okay? And then go find a room that you can both sit in a chair and not stand up, and explain that you're here to talk to them about their child's condition. And so you're starting with the right setting, the right circumstances. You start the meeting off in a certain way by introducing sort of an idea of what this is about, and then you begin with questions about where they're at. So it's like the next thing is, what do you understand about your son's condition? So starting from after they've answered that back, you understand where they're at, and you take it up from there, from what they've said, and feedback, and then give pieces of information that are digestible. If it's a big piece of information with a big emotional content, if it's something like the mom says to you, well, I hope it's just anemia and not leukemia, and you have to come back and say, well, the blood test is showing abnormal cells, as in leukemia. If you're going to say that kind of a line, you better be prepared to stop talking completely.
completely after and just let the person absorb that. So I'm really sorry, but the blood test is showing abnormal cells that may be leukemia. Stop. Just stop. And wait. So wait till she tells you or he tells you anything. Wait to see that they are ready to ask a question. As opposed to what I have seen, people just keep talking. And we can do a lot of our own stress and anxiety. I know there's a lot we can do, and there's treatment cure. And you're talking, and the person is, all they hear is one word in their head, leukemia. Oh my God, leukemia. And the doctor is still talking, and we'll do this treatment. What? Like leukemia? What? And so it's being aware that you can't just go on and on. So there's ways of doing it that are less dysfunctional than other ways. But being mindful of the fact that you've just given a big piece of information to somebody that's going to take the testing, and stopping your own internal anxiety, because you don't want to stop talking. You want to keep talking, so you can talk and talk and talk and leave, because there's a lot of pain. You don't really want to be there for an hour and not all that pain. Being aware that this isn't about you and is very helpful at the same time.
Okay, so I really like that because he emphasized, did y'all hear it okay? Okay, oh, sorry. Okay, so he emphasized that pause and how important it is. And also reflecting on our own level of stress and anxiety when discussing serious diagnoses or mortality and how that may impact the actual delivery of that information. So there was a real shift in patient-physician communication in the 80s. There was a survey in 1982 of about 1,200 Americans that indicated 96% wished to be told if they had cancer, and 85% wished to be told if they had grave prognosis, and to be given a realistic estimate of how long they had to live. And over the years, a number of studies in the US have supported these findings, and that most adult patients would like to be collaborative. In pediatrics, physicians prefer to be collaborative with families as well, but may not be implementing strategies to keep us on track with our communication. So a technical report published in 2008 in Pediatrics by Levital et al. Is a great review. It covers evidence regarding clinical communication in various pediatric settings. And it also has suggestions to enable us to be more effective, efficient, and empathic in our communication. So taking that time to build rapport and understand the child and the family, it really enhances the patient outcomes and their overall satisfaction. So when thinking about the communication between us, the parent, and the child, there's three main elements. There's informativeness, which is the quantity and the quality of the health information that the physician is giving to them, and interpersonal sensitivity, the actual behaviors that reflect the doctor's attention to and the interest in the parents and the child's feelings and concerns. And partnership building, where the physician invites the parents. And these invitations are nearly always welcomed by the family. As we place more attention, more emphasis on empathic sharing of life-altering information, this will automatically result in improved skills, and that helps as the stakes get higher when we're dealing with terminal conditions. So I hate to be the bearer of bad news. All right, so what are the barriers? Sharing life-altering information, it can be particularly stressful, especially when we are inexperienced, or the patient is young, or the prospects are very limited for successful treatment. So in 1998, the annual meeting of the American Society of Clinical Oncology, about 500 adult oncologists were asked various questions regarding communicating bad news. So when asked, what do you feel is the most difficult part of discussing bad news, 58% ranked how to be honest with the patient and not destroy hope as the most difficult. And I think a large part of this is the fear of taking away hope, but we may also be afraid of evoking emotion and not knowing how to manage that. So despite this, less than 5% received formal training. Only 38% had the opportunity to observe such a discussion, but sometimes we may not get as good examples. And some had formal training and observed up to observed it, but up to 42% had neither. And that was a bit concerning to me because these are providers who have to tell their patients that they have cancer. So when asked, when you break bad news, do you have a plan, do you have a strategy? About 22% had some plans but no consistent approach. 52% had some plans but no consistent approach, and about 22 had no consistent approach to discussing these bad news. So these were the results of discussing with adult oncologists. When talking to pediatric residents, one study showed that only 27% of the residents felt confident in giving bad news when the child is ill in particular. And this was although 90% of those perceived it to be a very important skill. And another study, more than half of 143 residents had never even observed the conveying of bad news. And I think for clinicians in general, additional training could be useful and only increase our confidence of disclosing unfavorable information. So the goals of sharing unexpected news, that interview has 4 essential goals. So gathering information, providing intelligible information according to the patient or the parent, and supporting the patient or parent by employing those skills that we learned in med school that include nurse, naming, understanding, respecting, supporting, exploring, and these are all to reduce that emotional impact to the patient or the parent, and also developing a strategy in the form of a treatment plan that with the input and cooperation of the patient. So I have some bad news to deliver. Please wait as I consult my protocol. Okay, so that brings us to spikes. Has anyone heard about spikes or what it is? Okay. So what those authors who published that ASCO survey did was they took those 4 essential goals and created this mnemonic, spikes. And it's a 6-item checklist for the aspects and elements of a skillfully driven bad news interview. So while doing that, it also addresses and gives us a lot of strategies to address the patient's distress. And this has been used in adults and published in the oncology literature. However, very few original studies have been conducted to develop or compare strategies when conveying bad news in pediatrics. Luckily, a modified version of spikes was published in the Journal of Palliative Medicine for Pediatrics, which has made it more peds-friendly. And they formulated a set of guidelines, which I think is a really great way for those of us who want that structured approach to these discussions. So we're just going to go through each of those letters here. So the first S is for setting. Are we in a comfortable place? Do we have enough time to discuss everything? And have tissues ready. I think this doesn't get enough attention. You don't want to be scrambling for tissue. So I actually keep a little tissue pack in my pocket, and it just comes in handy. You never know when you'll need it. And determine who will be there. This is a big deal in pediatrics. So do they want the whole family there? Is it just one caregiver, extended family? As far as the team members, you want to consider to have a small team as possible when initially discussing. And then also talk to the parents. Do they want the patient there initially? If not, we have child life to help us if the patient will be separated. Because sometimes the parents don't want the patient there because they're not quite ready. And I feel like at times we do include patients who may not be ready, and sometimes we exclude patients who may be cognitively ready to accept that information. So it's something that we really need to figure out before we start talking. And some parents have actually wished to have that initial discussion directly to the patient themselves. They wanted to tell the patient. Be seated. Sitting down really relaxes the patient and is a sign that you will not rush. So when you try to sit, try not to have any barriers between you and that person. Sometimes parents were confused about the role of trainees in caring for their child. So explain those roles up front and ask them on a continuing basis each time you encounter them. Is it okay for so-and-so to come in? And give them that option. So we should make it clear how everyone is going to work together and care for their child. Of course, minimize interruptions. You can set your phone to silent and have a colleague answer your pages. Perception. So here we use the axiom, before you tell, ask. And this should be done using open-ended questions. What have you been told so far about your child's medical situation? What is your understanding of why did we order this MRI? What did your PCP tell you before admitting your child to the hospital? And correct misinformation. One question that I have seen asked is, do you know anyone who has this diagnosis? For example, a child or a family who has just been told that their child has diabetes, their mind may immediately think to that family member who has uncontrolled type 2, who recently had their legs amputated. So we need to find out what are they worried about the most. And it's best to talk to them about it early on. Another thing is you want to find out what are their expectations. Do they expect this visit to be diagnostic or is it therapeutic? So the I originally stood for invitation when the patient was given the option to receive the full information about their diagnosis or not. But the modified I, the one that they modified for pediatrics, stands for involvement, where the real collaborative part, the sharing of information, comes in. And this is where we encourage questions, we engage the family and the patient as much as possible, and ask, does anything need to be repeated? Do we need to take a break? Am I overloading you? Should I come back in a few minutes? And if the family is agreeable, especially for the older patient, involve the patient in the discussion. And you can talk to them directly and ask the patient, tell us, what do you understand what's going on? What do you feel? What questions do you have? And at least you've given the patient that opportunity. And of course, be sensitive. If they don't speak our language or we don't understand their culture, just be cognizant of that before going in, and you can ask help when needed. So knowledge is probably the easiest one, and we are generally pretty good at it. The warning shot is very important. I have some difficult news to share. And this is where we discuss the actual details, what we need to do, the plan. And the important points are to provide medical information, but not overload or mislead the family. I've seen that writing things out in a diagram really helps understanding and to explain things to the family. And also know what tools are available to you. And they can be from something simple like an asthma action plan or knowing what the local support groups for leukemia are. And this may also be a point where it would be fair to ask, do we need to take a break? And be sure to pause and repeat as needed, and just make sure you assess how are they understanding, and being attentive to that is important. So emotion. In the literature, this is seen to be by far the most challenging. So to be able to manage those negative emotions that we sometimes elicit from the family and being able to respond to it empathically is difficult. We never know what response we're going to get. Are they going to be angry? Are they going to be sad? Will they just not be able to take in what we're saying? Are they going to be silent? So this is a hard one to prepare for too, but something we should be ready for. And I think that most parents want us to step out from our professional role and just really acknowledge that this is hard for them and the patient. So this can go a long way, and I think we can become better at it. Even saying something like, I can't imagine what you're going through, or I wish I was telling you something different, or I wish I had different news can really be more appropriate. And I've stayed away from using phrases like, I'm sorry, because when we say I'm sorry, that implies that we've done something wrong or a sense of pity, and that can just make things worse in that situation. So I think it's more powerful to say phrases that start with I wish. And it's easy to understand then why in those respondents in that ASCO survey said that the emotional part was the most difficult. So the last S is for strategy, summary, and self-reflection. I think this is also something we probably do pretty well. We summarize a lot with the families, but this is where we engage in shared decision-making if the family wants it, and you can work within that value set of the family and encourage hope. And emphasize when the whole team is available. Let them know when you're going to follow up, when you're going to call them next, and I think that's really appreciated. And let them know that you're going to do this together. So the other part of the last S is about offering choices, and it's a big part here. And also to offer help with sharing information with others. And we have a great resource here for our hospitalized information, which is Child Life. I think we should definitely utilize that more. And many parents report that being directed to or having those support services really made a huge difference to them. And finally, self-reflection. I think that's really helpful to bring up. Take that time before you go and see the next patient. How did that go? Could it have gone better? It would be a good idea to refocus yourself before you move on and see your next patients. So now that we've learned the modified spikes, I found this video. It's not from the folks that actually made the guidelines, but it's from the Duke University Medical Center, and we'll just review it. You guys can let me know what you think.
Mr. and Mrs. Jones, I'm Dr. Anderson. I'm the neurosurgeon. The pediatricians called me because Jimmy had an MRI scan, and it looks like the MRI scan shows a brain tumor. I looked at it myself, and it shows a lesion in the cerebellum, tumor in the cerebellum that we're going to have to deal with. So we've checked out my OR schedule on the way up here, and it looks like Tuesday afternoon we can do a surgery.
Are you sure you were talking about the right?
Yeah, little Jimmy, about 4 years old. I walked by his bed when I was coming up here. He was still just coming out of the MRI scanner.
But we thought he had the flu. I mean, he's just had some nausea and some headache.
Yeah, sometimes these brain tumors can push on the back of the brain, and where they push can cause nausea and vomiting. And sometimes it mimics, well, no, it's not the flu, it's a brain tumor. So we set up the surgery for Tuesday. The pediatricians will come in and tell you what Betty's going to. I don't know what Betty's going to yet. We're going to keep him in the hospital till Tuesday's surgery. Looks like it'll be in the afternoon. Any other questions?
I want to see him.
He'll be up here in a little while. I don't know. I didn't see him. I just saw him laying in the bed. The nurses were taking care of him. But any other questions?
I just can't believe it.
Well, we may have some time to talk before the surgery on Tuesday, all right? All right, well, the pediatricians will be in a little bit, okay?
Okay, so that was pretty bad, right? Okay, so now we'll see a good example of what to do.
Hi, Mr. and Mrs. Jones. I'm Dr. Anderson, the neurosurgeon. It's nice to meet you. Can you tell me a little bit about what's been going on with Jimmy?
Well, go ahead.
He was sick last week, just all this week, having, throwing up and headaches, and just really intensely sick and just not kicking it. Yeah.
So, and we know there's a flu going around, so we just wanted to make sure it wasn't anything more serious.
Yeah, just worry about his immune system.
And then they wanted to give him an MRI here, so
yeah. They said to roll things out, but
he's been gone for 4 hours now. We've been waiting. So,
yeah.
So he's been sick for about a week and throwing up and headaches. And I know you've been waiting a long time, and I'm sorry about that. They have to sedate him a little bit to get him to hold still for the MRI scan.
Is he scared? Is he okay?
He's okay. I just saw him, and he was basically like waking up from a long nap. So he's moving around, and he looks fine. He's opening his eyes, but he's still not kind of back to his normal self yet. The nurses are watching him really closely, and everything's fine with him. I looked at the MRI scan, and I'm afraid I have some bad news for you. It looks like he's got a brain tumor.
sure?
Yeah, I checked very carefully the scan and him, and it fits with the symptoms he's having, and he's got a small brain tumor back here in his cerebellum on the right side.
I just thought he had to, we just thought it was, I mean, we thought it was kind of silly we even came in today.
Sometimes these present that way. People, the little kids are sick and they're nauseous and vomiting, but it turns out it's actually pressure on the back of the brain that's causing them to have the headaches and that kind of thing.
This is really a shock. I just,
I don't know why.
I'm so just done.
I didn't even know why they wanted to get him an MRI.
Oh my God.
I know this must be really hard news to hear.
Is he going to be okay?
He's going to be okay. We're going to be with you every step of the way. Would you mind if I tell you a little bit about what the plan's going to be, what the next step is, so we can keep taking good care of him? So I can tell you one thing, in looking at the MRI scan, sometimes these, you can tell whether they're more slow-growing benign tumors or more fast-growing aggressive tumors. And the good news is it's the more small-growing benign type tumor it looks like. We won't know for sure till we take it out, but we're going to have to do surgery to get it out and try to cure him from this brain tumor.
So it's a benign one, you think it's...
We hope so. We'll know once we look at it under the microscope, but looking at the MRI scan, that would be the more likely scenario.
That's what it looks like. It's not just that you're going to rule out, I mean, it's probably benign then, so...
Where it's located, it looks like that, yes. So we've looked at the schedule, and we want to admit him to the hospital tonight, and we'll keep him here over tomorrow and give him some steroids to get the swelling down, so he'll feel better. And then Tuesday morning, we'll do the surgery, and the surgery will last about 3 hours.
In a couple of days, yeah. So, can we see him? Is he?
Yeah, he's going to be right up. The nurses were just about ready to, they were getting him all ready in the bed, and he was, like I said, waking up from like a long nap, and he's going to be up here in about 5 minutes. And I know that's a lot to take in, but what questions do you have?
I don't know. I'm just so floored right now. Do you?
How long do you think he's going to be in the hospital after the surgery, if things go okay?
Things go well. He should be able to go home by next weekend. So tonight's Sunday night, so I have surgery Tuesday. Should be able to go home by, Friday, Saturday.
He's just going to be okay. He's going to be okay.
We're going to be with him every step of the way with you guys, and if you want to, I'll come back in a little bit and we can talk, once you've had a chance to kind of process a little bit of this stuff, we can talk with him and tell him he's going to have, a little surgery on Tuesday.
Yeah, I think that would be helpful,
Yeah.
I'm not sure what I would say.
I don't know.
Your job's just to be mom and dad. We'll be the neurosurgeons, okay? We'll take good care of them, all right? All right, take care.
Okay, so does anyone want to talk about any of the elements of spikes that we saw in the good example? The bad example was pretty bad. So he sits down and he remains seated the entire time. He made sure he asked. He got that perception of what the parents thought what was going on, and he involved them. He, elicited those questions, and he also talked about involving the patient towards the end. And that warning shot, I'm afraid I have some difficult news I have to share. And he pauses. Even though it's difficult to pause, we want to rush, we want to talk and fill that gap and to alleviate our own stress, but we really can't. We have to, take that breath and just give them time to process. And those pauses can be very effective for the family. He used empathy. He named their emotion, and he explored more as far as what questions that they had. And then he asked the parents, do they want him to come back later and discuss further? And I really, I like that part. And lastly, he offers them hope, but he's realistic. He offers that realism for them as well. Do you have any questions about that? Okay.
One comment.
Yes, sir.
He could have sat with the parents so the bed wasn't between him and the parents.
That's a really good point. And I completely agree. Any kind of barriers between you and the yeah.
Like that, tables and stuff, you want to be fairly close.
Yeah, thank you. That's a really good point. So this table is from the paper, from the group that developed those modified guidelines for pediatrics. And what they did is they put those guidelines to test on their own residents, their med students and their faculty. And they showed about a 1-hour training module, and they presented it at 5 different educational conferences. They had some didactic sessions, they had videotaped parent recollections, they had some group critiques, kind of like what we just saw, you know, like an open discussion. And then they gathered data from pre and post surveys. When combined, they all showed a statistically significant change across the board. So that shows that each group, no matter if they were attending or a resident or even a med student, they had some improvement as far as what they reported. And each individual group exhibited increases in most objectives, but the medical trainees definitely had the largest increase. And then, despite training in sharing of life-altering information, there were significant increases for each objective that they had. So I understood what was going on. I knew what she was going through. I really had a strong trust for the doctors on that team. They explained everything I needed to know. And this is what one parent said in appreciation of being presented with candid and straightforward information in the PICU. So just to talk about some specific clinical environments, there's been studies of interactions with families in children in the ICUs that show that the guidelines are good, but sometimes in the situations where there's a lot of uncertainty, there's a lot of rapid changes in the child's condition that actually require more intense and frequent communications, they had a little bit different aspect as far as what they rated were the most important things. Attitudes of the clinician, clarity of the message. These were leading considerations for families of trauma victims. And families prioritized knowing that everything was being done and the ability to be with that critically ill or dying child were the most important to them. And factors like sympathy and the location of the discussion and time for questions, they were rated as intermediate in these situations. So what do we have from the AAP? There's this technical report, it's about 20 pages, published in 2014. It addresses many special considerations when you have the sudden traumatic death of a child. And it includes the parental presence during any attempted resuscitation, the legal requirements, the request for organ donation, and the impact on the siblings, other family members, and the hospital staff. There's also this booklet, After a Loved One Dies, How Children Grieve. It was published in 2009, and it was created to be of value to parents and other caregivers as they help children cope with their grief and the fear following a death in the family. And other important topics it had were, really teaching the children to cope over time. So, teaching skills to share life-altering information, there's been a wide range of strategies that educate medical students and residents about doing this. And mixed strategies are really common. Videos, patient, whether they're real or standardized, personal experiences and lectures or seminars, and case-based discussion and role play are really common as well. The majority of articles describe specific interventions that range from either one-time seminars or workshops, but that they integrate these things into an ongoing curriculum in these individual training programs. And the overall theme is that these participants, they really do state an improvement in their skills after, and the comfort level for them after the training. And there's an emphasis on the need that this education should really be continued throughout their training and even afterwards. So some more resources. We have these web-based materials that have been developed by the Initiative of Pediatric Palliative Care and the American Academy on Communication and Healthcare. These websites are really good. They have a lot of videos, a lot of quick guides. And then this Breaking Bad News Foundation. So this was actually developed by a neonatologist, Dr. Anthony Orsini, at Winnie Palmer in Orlando, Florida. And so they have 1 hour webinars and even 2 to 3 day in-person courses.
All right, my name is Dr. Saxberg. It's nice to meet you.
I think it would have been good to say who you are specifically, to introduce yourself, but to say that I'm the neonatologist that's taking care of Stella.
We, as physicians, are not really taught how to deliver bad news. You might get a pointer here or there and you observe people. Sometimes you're observing people who aren't very good at it, so that may not be the best way to learn. And it's emotional for the person delivering the news also.
The actors felt you picked up their cues beautifully.
It takes some skill to learn how to do that in such a way that the family or patient really feels that you are a partner with them and supportive of them as opposed to just a person delivering a piece of information.
Today was the first day of the Breaking Bad News program that teaches resident physicians and senior physicians on how to discuss tragic news with patients and their families in the most effective and compassionate manner.
It seemed like a definitive place where the residents would have a need.
And at any point in the video, I should be able to stop it and say, do you think the good news or the bad news is coming? And at this point, I think there's really no indication that Stella's dying. You had your plan when you walked in, and now you're going over the review. You're trying to get on the same page as them.
It's definitely interesting, and it's good to hear just what other people have to say, and like very non-judgmental, just like it's good to be in a controlled situation like this before it's a real situation.
I think it was fabulous.
You're a caring doctor that can show it, so you're 90% there.
Coming out of it and reviewing the video and getting all the tips and pointers and this is what you did well and this is where you can improve. They all actually came back saying it was incredibly useful and they felt like it was a really valuable experience.
And so by training one physician, hopefully we're benefiting many, many families.
I thought that was a pretty good program they have. So some more resources available include something called Vital Talk. So I actually came to know of this through my discussions with Dr. Wadwa. She's our new hem-onc attending, and I really like this resource. The Vital Tips app is what's shown here, and it's quite resourceful and it's free, so you can download it now if you wanted. And Vital Talk was founded by a team of adult oncologists and other specialists in palliative care. And the website has multiple free quick guides as well as videos, and I thought it was very helpful. They have online courses as well, and you can even participate in a one-day course in the Bay Area or DC. So just some additional tips as we wrap up from, some things that I've learned too that I didn't talk about is, and I'm very much still learning, a couple of things is utilize our resources. We have Child Life. Stephanie is a great asset that we have on the floor in the PICU, and I cannot tell you how many patients of mine she has helped. She's really making quite a difference for them and their families. Attendings, they have seen so much more. They are a wealth of information. So just ask them, what do they do? And request to be there when such discussions happen. And I've been fortunate to have seen very good examples of these discussions. And nurses, many of them have been doing this a lot longer than we have. And especially in the PICU, some of, they can really give you some guidance when you're there by yourself at night. Be aware of the importance of maintaining eye contact. That is really important. And your body language. Parents pay attention to who is doing what in the room. You don't want to go into a room all smiling and then share some unexpected news. They but they don't also want you to be distant. So a good balance between both of those. And then self-care. You know, it's always better to talk about these things with your colleague, debrief with someone, and know that you're not alone in this. So in summary, instead of delivering bad news, we're sharing life-altering information or sharing unexpected news. And this is a subtle but really powerful distinction. We recognize that effective, empathic communication is an essential skill for us as we care for our PEDS patients and their families. We're thinking about these discussions before we walk in with these guidelines that are customized to the PEDS setting. How is this going to affect the patient and the family and their lives? What are their perceptions? Are we doing it at a time and place that is the best, that's comfortable? And also allowing yourself to reflect on how things can go better. And of course, utilizing resources to improve our own communication skills. And this will eventually lead to a lessen emotional stress for us as well as the family. And hopefully get to an overall increased, better understanding. And that is a lot of references. And thank you for your attention. Any questions, comments?
Marge, that was an excellent presentation, really well done, and I think everybody would learn from that. Stephanie.
Hey, can I just say something? I'm Stephanie, if y'all don't know me, I'm the child life specialist. It may sound really silly, but practice those tough conversations with each other. Role play. So that the first time you've ever said the words, your child is dying, you've actually said them before. My door is always open. If y'all ever have questions, I have lots of resources. If you want me to role play with you, I can give you tips and pointers on things to say, things to avoid, and kind of give you feedback. Also, what she was saying, St. Jude has an amazing palliative care conference that they do every year. It's actually led by bereaved parents. And if you've ever had the opportunity to visit with a bereaved parent before, please utilize them if you ever meet someone that's willing to discuss with you what they've gone through. I was able to role play with a bereaved parent, and one of the main things that they said to us is avoid the words, "I understand." Even if you mean it out of empathy or support, you don't understand. Even if you've lost a child, you still don't understand what they're going through in that moment right then. So, great job, Maj.
Thank you, Stephanie. I appreciate that.
Monty.
Yeah. That was an excellent overview. You started off with cancer, or somebody comes in with routine symptoms of flu and turns out to be a devastating diagnosis, as well demonstrated in the neurosurgical video there. So that's my comment. I have several questions. I assume from your presentation we do not have a palliative resource in the hospital, because most large children's hospitals or oncology centers or large hospitals have one where people are actually both certified in palliative care and come and interact with you. I assume the answer is no. We don't have palliative care. Okay. So getting back to your presentation, again from my life experience, whatever it's worth, to me, different cultures are different. What I've experienced here in the South, religion is a very important part of it. So first person through our social worker, we try to talk to the parent and family is, would they want their priest? Would they want our hospital priest there? And as you correctly pointed out, we try to keep it to a minimum. I always feel the attending has to be the key person who's running the show, and they have to really rehearse with them and the nurse and the primary nursing care provider what's going on. And as you very nicely pointed out, keep the first meeting brief and use that as a listening. And there are excellent, lots of reviews, papers, perinatal clinics that have been written in neonatology, but you have to come back over and over and over again to revisit them after they have had a chance to digest. So again, chronic care, the bad news of cancer and death, because one of the challenges we face, and again, if you go and look at the AAP resources, that one of the burden of responsibility to us as pediatricians is, it's a difficult one, that you do not want to prolong death. That has been studied extensively in adults, children, because we know that cancer, sometimes your treatment is only prolonging by a few months. Same way for our babies, they're going to, so you have to revisit that very, very carefully as to how the whole family, and you made an excellent point about support system, and she reiterated that. We use that, try to use that for syndromic illnesses, like Down syndrome or others, because there's no way you know or I know what they are going through. It is that several families, and there's a spectrum of diseases in Downs or radiant trisomy or whatever.
Diana?
A couple of things that I run into with parents. One is they, whether they ask it at some point in time or not, they frequently wonder if they did or did something or did not do something that caused this to happen in the child. And so if you're aware of that, specifically addressing that issue, whether they have asked or not, I think is important. And give them true information. But they're going to, at some point in time, they're going to wonder about that. And another thing is that denial is such a protective mechanism for the psyche that there is a lot that they are not going to remember having heard when you talk to them, even multiple times. So just because you have given them information about a certain thing once doesn't mean they're going to remember it. And they may ask the same question over multiple visits. And don't get irritated. Don't think they weren't listening. It's their way of processing things. So expect to have to repeat things multiple times for them to understand what's going on.
A lot of the parents say as soon as you say something that they did not expect, they get this tunnel vision that goes backwards, and they go deaf. Everything sounds muted. So their sensory effects are there too.
Right.
Luki?
Just 2 points. We're very fortunate in this program. We have very diverse people from different backgrounds and cultures and religions. So take advantage of it. Cultural sensitivity is very, very important. We kind of downplay it. I've seen a lot of times, sometimes there'll be someone of maybe Middle Eastern or Indo-Pak origin, and people will come grab me, do you speak their language? Like, be culturally sensitive. Yes, they may wear a scarf, I may wear a scarf, may both be Muslim, but it doesn't mean we speak the same language. So pay attention, talk to people, ask questions. It's okay, just learn about other people's culture. That way when you approach patients, you know what to do. To touch on Dr. Bienvenu's point about, talking about emotions and people in denial, it's very real. So don't get irritated, it's so important. And personal example, when I was pregnant with my twins, and I remember when the high risk obstetrician told me, I think you have twin transfusion and you need to go for laser ablation and one of your twins may not make it. And I just sat there and I couldn't process the information. And I'm a physician, my husband's a physician. And he kept asking, do you have any questions? Do you have any questions? And we just looked at him and we just walked out. And when I got home, I told my husband, why didn't you ask any question? You're always more calm, but we just couldn't measure the emotion because it was so unexpected. So if your patients are not able to respond back to you in that moment, try and understand and empathize, and then just go over and over again as many times as you can. Because if you're really not going through it, you really cannot understand what that person is feeling and how overwhelming those emotions can be. So just be a little patient with your patients and kind of just try to empathize. And yeah, that was just
Yeah, one detail in the video presentation, the doctor's talking with the patients with the parents over the phone. He says, I have some news to talk to you, and can we meet in my office at 9 a.m. tomorrow? That's a very hard thing to do because they're going to want to know right then what is it, and the risk is that you have to give the whole counseling session over the phone. So do you have any clues as to how you get out of that situation? I think that's really important. you do have to arrange it, and it's often over the phone. So how do you get around that?
I think that's a really good point. I've actually come across that too, just like in the clinic, if we have to give something, some information.
Sometimes I think what you do when you know when to expect something back, I will have you come back and whatever the news will be.
Set up an
And already
appointment.
have the appointment.
Set up the appointment at the beginning when you're making setting up the appointment.
Especially after autopsy.
Setting up
The follow-up.
first diagnostic.
Right, and give them the
Okay.
results.
Yeah.
Yeah, when you
So
can.
you set the rules right then. Yeah. Okay.
In your last video, you brought out an important point, which, as you know, is the gold standard, but unfortunately, we don't. It's a gold standard that came from neonatal resuscitation. We use it all the time. We use there are several top NICUs which will use any resuscitation of video and then debrief. What you showed there is as simple as debriefing, except that it's translated to a bad news here. So as you heard in the video, the guy was saying, he's a neonatologist, stop the video here. So that's what we do when we go out and teach all over. But okay, let's stop it. Then we ask everybody, what do you think? How would you have handled it? So I'm suggesting that maybe we could develop a program for teaching here, because that's a very effective. As you know, the whole thing came from Scully, the pilot who were trained thousands of times to handle emergencies. So it becomes a second nature, if you will. Any comments? I don't know.
Well, I know that we have talked, and I don't know where Dr. Cooper is on this, about kind of having a discussion after specific events to kind of make sure everybody understands what happened and how to address the emotions that created for everybody. And that has certainly proven to be a good way, not only for people to understand the event and learn from it, but also to benefit emotionally from discussing it.
How would you improve the next time?
Right.
What went right, what went wrong?
And working through any issues that someone might have based on how they feel about how well they performed or how what may have been missed. So that's another aspect that's really important to training that certainly is evolving. Yeah. Okay, Maj, a great presentation. I think that it's very clear that there are a number of resources available for our residents, and that many opportunities to learn how to do this very effectively. And it is a really important part of what you do as a physician. So I think it's really important to incorporate this, and I think Maj is another resource for us now. So thanks. All right. Great.
Thank you.